آه سوري يا اخوانا for inconvenience. فthese subtypes يعني افتكر الكلام ده almost بتكون اخدتوه في في الفيرولوجي. ما هنركز كتير في الميجر difference between هنركز على immunology and the natural history of HIV. Usually HIV host cells infected with HIV have a very short lifespan. HIV continuously use the new host cell and replicate itself. Up to 10 million individual viruses are produced daily, and during the first 24 hours after exposure, the virus attacks or it captures dendritic cell اللي هي دي the CD4 cell. Within 5 days of exposure, infected cells make their way to the lymph nodes and then to the peripheral blood, where the viral replication becomes very rapid. This virus entry. Initially, the virus will be attached to the CCR5 cell, where they come into the cell, and through replication, though the replication of the virus will occur through the reverse transcriptase enzyme, and viral replication occur, and then new virus will be released. Primary infection. This is at the time of infection, the patient develop seroconversion illness, which is stage of fever, skin rash, lymphadenopathy, and then the disease progression, and where immune depletion occur, and intermediate immune depletion also occur, and later the patient develop advanced immune depletion. So the immune depletion occur early, then intermediate, and then advanced. At the virus entry, you can see this high curve where the virus replication was very high, and then the viral load will increase and then increase gradually over few years. And initially the patient have very high CD4, this is the blue line, and then over few years the CD4 count will reduce. Viral transmission, acute retroviral syndrome. As I said, the patient develop fever, skin rash, lymphadenopathy, and so on. And then recovery from seroconversion, and the patient become asymptomatic for 8 to 10 years. And then the patient will become symptomatic after a few years. And later on, as the disease progresses, without treatment, the patient will die of HIV. The patient is symptomatic in 50%, and the patient will develop feature of mononucleosis like syndrome, اللي هي skin rash, fever, myalgia, fatigue, headache, lymphadenopathy, and even the patient may develop aseptic meningoencephalitis initially. The duration of seroconversion usually 8 weeks, and the average duration is 14 days. Severe and prolonged symptoms are correlated with the rapid disease progression. Differential diagnosis of Seroconversion is infectious mononucleosis, toxoplasmosis, secondary syphilis, drug interaction, rubella, and as I said, in the first few weeks, the patient developed a reduction in the CD4, reduction in the CD4 count, and expansion of the CD8 and thrombocytopenia. Usually during this period, the ELISA is negative. For those is what we call the window period. عشان كده لما يجي زول بريسك behavior في الأيام الأولى نقول له امشي وتعال بعد 3 شهور. and negative or evolving. عشان كده it is better إنه دايما نعمل لهم western blot or western blot also may be negative. And you may do HIV RNA level, and usually it will be more than 50 copies. B24 antigen is less negative in the primary infection. The clinical management of seroconversion is usually symptomatic treatment. Advanced immune depletion, this usually occurs when the CD4 becomes less than 200, and this stage the patient will start to have AIDS. As I said, initially the CD4 count, the CD4 is a master of the immune system, that to say, the cell which regulates the immune system. So initially the CD4 count is high and the body is healthy. Later on, when the HIV start to infection like fever, like cough, when it start to attack any human being, the CD4 will defend the body. But when HIV enters the body, as you know, the HIV has a prediction to the CD4, and the HIV destroys the CD4, and so the patient will be alone without any defense mechanism. So a lot of infectious disease like cough, like diarrhea will attack the human, and the patient then become very weak and immune compromised with a lot of opportunistic infection. As you can see, initially the patient is very healthy, the CD4 count is high and the viral load is low. Later on, the patient will become weaker, and then weaker, and then weaker, and lastly the viral load will be higher than the CD4, and the patient within 10 years will develop frank feature of HIV. Opportunistic infections, that is infections that take the advantage of weakness of immune system to cause disease. As the CD4 declines, the normal CD4 count, as you know, is 450 to 1,500. As the CD4 count declines to less than 400, the patient will start to have opportunistic infection. This is the clinical stage 1, where the patient is symptomatic or just have persistent lymphadenitis or primary infection. Stage 2, unintentional weight loss and unexplained weight loss, major mucocutaneous manifestation like seborrheic dermatitis, papillary skin rash, fungal nail infection, uncomplicated herpes zoster, recurrent upper respiratory tract infection, and thrombocytopenia. This is stage 1. The patient stage 2 where the patient have herpes zoster, and here patient have fungal skin infection, tinea pedis, or acyclic foot, and here the patient have papillary skin rash, and here this have seborrheic dermatitis, and here the patient have angular cheilitis and stomatitis. Stage 3 unintentional weight loss. The patient have body mass index less than 18, or chronic diarrhea, prolonged fever, oral candidiasis, hairy leukoplakia, pulmonary tuberculosis, and severe bacterial infection like pneumonia, polymyositis, and bacterial meningitis. Also, the patient may have bacterial angiomatosis and complicated herpes zoster. This candida infection of the mouth, and this is hairy leukoplakia, and this is stage 4 HIV wasting syndrome, toxoplasmosis of the brain, cysticercosis, isosporoiasis with diarrhea, aspergillosis with diarrhea, and extrapulmonary cryptococcosis, cytomegalovirus encephalitis, herpes simplex infection, progressive multifocal leukoencephalopathy, and disseminated endemic mycosis, candidiasis, non-TB, extrapulmonary TB, lymphoma, Kaposi sarcoma, and HIV encephalopathy. Later on, the patient developed invasive cervical carcinoma, major abscess ulceration, nephropathy and renal failure, unexplained cardiomyopathy, visceral lymphadenitis, and stranguloides hyperinfection syndrome. This wasting syndrome, you can see this patient is massive weight loss with plus chronic diarrhea, and this is a patient with pneumocystis carniae pneumonia, and this patient with toxoplasma of the brain, and this patient with Kaposi sarcoma, and this is a patient also with Kaposi sarcoma. This is another patient of Kaposi sarcoma of the nose, and this is a patient of Kaposi sarcoma of the mouth, and this patient with lymphoma of the gingiva, and this patient with extrapulmonary tuberculous lymphadenitis, and this patient with cervical herpes, chronic extensive genital herpes simplex infection. Thank you.